Welcome to New Zealand, Mansel.
Thank you.
Can you tell me a little bit about what's drawn you to New Zealand?
Yeah. Well, first of all, there's a sort of enduring relationship between New Zealand and Wales. You know, we play rugby, we've got a lot of sheep, and the populations are about the same. But more importantly, from my point of view, coming from a healthcare and public health background, the sort of problems that we have in our communities and the types of challenge to our healthcare systems are very similar.
So Mansel, as you know, we face significant challenges in Northland, and we've developed a Northland Health Service Plan.
Yeah.
And some of the challenges are around poverty and inequity and our ageing population, and obviously also the fact that we have a large Maori population with significant health challenges. What impact does the inequity, ageing population and our Maori population have on our communities and on the provision of healthcare?
Yeah, well, I think they have the most profound. You know, it irritates me sometimes when I talk to people who say, well, we need to have more money spent on healthcare, that we need to have the best instruments that are possible, that we need to build more and more hospitals. They're missing the point. Because it's inequity, it's deprivation, it's social disadvantage, it's social exclusion, and poverty, let's be honest about it, that actually is the bed within which ill health and disease is brewed, you know. That's a mixed metaphor, but I think you know what I mean.
Yes.
And unless we are hopeful of doing something about that, then just delivering the best healthcare system in the world will help tremendously. I've got nothing against healthcare being delivered in a quality way and in a safe way, but unless we tackle the underlying social determinants of ill health, we will not succeed as a society. And New Zealand is no different to Wales, albeit there is an ethnic difference in that you have Maori and Pacific Island populations. But my feeling is that although there are cultural issues that must be addressed, you know, I know that, the real reasons why we find higher levels of morbidity, disease, ill health, death, suicide, and indeed drug abuse, and longer and shorter lifespans among those communities, and they're in Pakeha communities as well, is due to the underlying poverty and deprivation. I've been working on looking at a study on growing up in New Zealand, which is being done in Auckland now and counties Manukau and Waikato, which is looking at the issues that are actually acting on the child before birth, in the womb, in fact before pregnancy in the mother, and certainly in the first year of life. And unless we tackle those, then whatever we do later will not have a major effect. We know that a child's brain is developed quite well in a normal pregnancy by the time of birth. But we've been looking at children whose brains are half the size, 3/4 the size of what they should be at birth because of the deprivation, the drug abuse, the poor nutrition, the anemia that occurs in pregnancy. And you'll never be able to catch up on. Those kids will never catch up. And when you're talking about, you know, teenage violence and sort of unusual behaviour, social misbehaviour, actually we're judging kids who, although they may appear to be 18, have brains of about 8-year-olds.
Sure.
And you know that you've got to have a different, and that's all because, you know, they didn't have the advantages they should have had when they were first born.
Yeah. I mean, it's interesting that we've had that recognised, and obviously Northland's sort of a perfect storm of all those conditions.
Absolutely.
You've talked about, but we very recently have been chosen as one of the 2 pilot sites for a program on vulnerable children.
I know, because I was talking to Paula Bennett recently about that, and about the recent initiative that she's put out about, you know, child abuse as well. You know, exactly. And that's a great program, I think, that needs to be followed up. I don't mean to, shall I also emphasise though that although I'm talking and emphasising population health, because I think that's very, very important, that doesn't mean to say we should take the brake off. And I know you feel that, you know, as in your report, you know, we've got to deliver a service that's the best that can be delivered. in Counties Manukau, we developed a phrase, to deliver a service which is as good as or better than anywhere else in the world.
Yeah.
And presumably Northland would want to do that too.
Absolutely.
Yeah.
Our focus within Northland is very much on operating a system which is without silos, both between primary care and hospital services.
Oh, yes.
But also within the greater, wider sector and all the agencies. Yeah. And so we formed a group of leaders, which is called the Northland Intersectoral Forum.
Yes.
And I was just wondering what you think of the value that we can attribute to working cooperatively in that way.
Oh, I think it's the objective. We talk about in Wales better integration between services, because what you find is that somebody is delivering a service in one area which either overlaps or is quite distant from another one. The patient or the citizen, as we now tend to say, should not be able to distinguish between the services that they have. It should be a nice sort of flow through, but that doesn't happen. We have silos and we have poor working. And we've been working towards integration of primary, community and secondary care, so that the person travels through life and travels through the illness, and the focus is on the patient's journey all the way through, and that doesn't happen. And I see that you are focusing a lot upon that. And I think unless you do that, you're not really going to achieve what we've always said is most important about the healthcare service, is for the patient to be at the focus of the service and to be receiving a service that, as I say, they do not distinguish who is delivering. It doesn't matter to them who delivers it. But what we find in Wales, I'm not sure about what it is in Northland, but we find that a lot of the costs because of bed occupancy is because people cannot be discharged from hospital into the community because the community services are not there, and the primary care services are not alerted to that. And we've been working very hard in Wales to improve that liaison so that it's a completely seamless service. I think it's paramount importance to achieve the best quality you can and the best in regard to patient safety as well.
Yeah. And I guess what we've seen and we talk about is the 6 cars up a driveway, where patients also, unless there's a coordination there, and particularly between different agencies, can end up getting the same service duplicated a number of times.
That's right.
And other patients, of course, miss out. So we're working very much around working with all of those agencies to try and make sure
bring them
that we
together.
Can bring them together.
And of course there's sort of a bit of tribalism sometimes between the services, aren't there?
Absolutely.
And a failure to recognise that they should be working together, not for their own good, but for the good of the patient.
Yeah. This interagency group we've got is now actually starting to try and share that information between the different agencies, particularly around vulnerable children, youth suicide, those sorts of things. Because we all have different bits of information, and we've got to actually work much more closely
information sharing, so important, I think. Another thing that we did recently was to look at child protection and safeguarding in the NHS in Wales. And it was remarkable how many of the problems were just due to the fact that the information that was known by one group was not shared with another. And that could have saved lives. Well, not could have, would have saved lives. Yeah.
What advice have you got for our staff, and what encouragement can you give them around providing a quality service, innovation, focus on patient safety?
Yeah. Well, I've spent my life in medicine and in healthcare, and it's been a very rewarding one. And it's, unless you are committed to the person that's at the end of the service, I use the end of the service as I don't like using the word service user or whatever. I still like to use the old word patient, right? And I still use that. But if you realise the patient is there and the patient is there for you to help, you get a tremendous reward which can't be met only by money. And it's a tremendous feeling to go home in the evening and think to yourself, well, during the day, I've actually helped somebody to have a better life. Now that sounds very altruistic and sort of blue skying rubbish. It's not. That's what's at the heart of it. And we often use the phrase which other people have used, nobody goes into work in the morning to kill a patient.
No, or do a bad job.
Or do a bad
Absolutely
job.
not, yeah.
But we do bad jobs, I'm afraid, and quite inadvertently. I mentioned the 1,000 Lives campaign. You know, there are lives, there are avoidable deaths. And if we realise how important we are in that picture, I think. I think that nowadays healthcare seems sometimes like to be a factory, you know. We're moving people along, but actually each touch matters.
Yes.
And our touch may be the most important touch to move people forward. So, you know, I think that's something to be proud of what you're doing. When you see people that have that glow within them, you can recognise it, and you can walk into a ward. You still use the word wards, do you?
Yes, we do.
And I can walk into a ward and I know immediately that what the patient feels like in that ward. It's an atmosphere. The people there are committed and donated and devoted. It doesn't mean to say they've got to be people who are sort of altruistic and high flyers and all that. They're people who actually want to do that job. And I noticed from the prizes that will be awarded on the day, how many of them are related to critically important quality improvements, doing something different, being innovative. And that's the other thing. Innovation sometimes is very simple things, you know, not big inventions, but doing something, just that little difference, which makes a difference to the patient, and it makes a patient to the patient's life in hospital and when outside. So I've seen those, and I've seen that there are a number of prizes that relate to patient safety as well.
Yes.
So, you know, if I'm on camera, I'm speaking to you and saying to you about an award, you know, really cherish it and shove it up in the ward with a certificate. They'll have a certificate, will they?
Yes.
Yeah, because people are proud of what you've done.
Absolutely.
Yeah.
You are the co-author of a white paper, A Case for Change,
Yep.
Moral Obligation in Pursuit of Quality. What lessons have you learnt that we could take away with us in Northland?
Good point. That's the piece of work that I did with Pam Muth and Jonathan Gray, who are two of the other authors.
Within counties.
Yeah, within counties managed
Yeah.
Manitou. And what we learned was that, relating to what I said earlier about quality and about the way people approach the patient, that clearly everybody wants to do a good job. But very often there are obstacles to doing that. And some of the obstacles one can look into, but at the bottom of it all is culture, right? A change so that actually the patient does become the person that you're serving, that you deliver quality in. And the definition of quality in my mind is, you know, to meet the needs of the people you serve. And people are doing that, but they've got their own agendas, their own obstacles to doing that. They belong to different groups. And there must be ownership, a common ownership of the view that, you know, putting the patient at the centre is the most important thing. And we think that tackling that has been the most, tackling culture, tackling the obstacles which are brought by people's beliefs and attitudes over the years, that's the most difficult thing to remove in making change for the better.
Yes.
So we thought one way forward would be to ensure that we had tackled that culture across the staff first, in the first instance, because actually the delivery of healthcare and better delivery of population health is not just the responsibility of people working in healthcare. It's the responsibility of all people, and particularly politicians too. You know, because politicians sometimes, by their own the way they sort of try to score points against each other, they inhibit improvement. So we thought that culture change is primarily one. And we considered that one of the most successful ways of doing that has been by the process of what's called motivational interviewing. You know? Helping people to understand the reasons why they feel they're unable to change. And that's really based on two big things, ignorance and competency. And once people have greater knowledge about what the change is needed and why it is needed, and that they really have the tools within themselves to do that, and are supported to do that, and it's a process of ownership, then we think, in the same way as you do health impact assessments when there's a new project, you say, you know, how is this going to affect the population that it's involved with? Then before making a change, you should look at the impact of change on people, discover what what their obstacles are, what their beliefs are, what their worries are, because many people are afraid of change. You know, the worst thing about change is to be frightened of it. And also that it threatens their jobs, or it threatens their futures, or they can't do it. And all these things can be sort of welded together to do a process of, say, motivational interviewing is taking these things forward. That's one. But the other thing that we explored in Case for Change really was leadership. We think leadership is extremely important, but not the leadership where you have a Führer or you have a heroic leader. I mean, yes, sometimes you need one person to drive it along, but we talk more about distributed leadership, you know, encouraging it, embracing it, nurturing it, and recognizing it, and then giving all the help you can and all the support you can to what I call nascent or new leaders or potential leaders, and bringing them along. And indeed, not just concentrating on one person, even in that group that you're developing, but the group can be a leader, you know. Sure. And I think unless you can't get change without changing people's attitudes, beliefs, and cultures, and you need a group of people who are all leaders, you know, and it doesn't matter what they do, whether they are working as a doctor, as a surgeon, as someone who is sweeping the floor, they're all leaders. And I think that's another area that we felt was very important, and I think Northland can learn that aspect from, you know. So there is a report called The Case for Change, and in that we've gone into some great detail about all the issues that we've been talking about today and what solutions we think we can offer.
So Mansel, having read that report, I noticed that there's also a third recommendation around the independent commentator panel.
That's correct. That's correct, yes. That arose out of the experience I've had in Wales, where we put together a group of people who were experts and impartial and independent, and could help in advising on reforms in healthcare. In fact, the Bevan Commission was commissioned by the First Minister, the Prime Minister in Wales, to look at the reforms of the NHS so that they could be recognisable to the reforms that came in 1947, when a chap called Aneurin Bevan, who was a Welshman, introduced the NHS. And that NHS was to be comprehensive. Everybody should be part of it, universal, indeed, included, and it should be free. And there were some worries and concerns that those principles were not perhaps going to be followed as they should be in Wales. So the Bevan Commission was put up to oversee that. Right. And they're a group of experts who have helped in informing the health boards in Wales, the National Health Board, in quality issues, in patient safety issues, in looking at various challenges, which, you know, the demography that you mentioned about the increasing populations, all those sort of things, give them some valid advice and counsel, but also have been in a position not to criticise, but to be a critical friend, and to say, look, you know, we're impartial and we want to help, but we think that this particular area that you're looking at is something where you could do something differently. And we know either we can give you that advice ourselves from our own experience, or we can put you in touch with someone else to do that. So it's a sort of critical friend, and a source of expert, impartial and independent advice from well-informed, nationally known and internationally known experts. People like Don Berwick are on there from America, and we've got others from the UK, and Gregor Costa, who's chair in Counties Manukau, he's also on the Bevan Commission. And we thought, when we were putting the paper together, in order to affect that change, in order to provide knowledge for counties to go ahead and become world class, which is what they want, they needed this panel. And indeed, hopefully that panel will one day perhaps not just be a county's resource, but be a national resource where Northland could call upon its expertise as well.
Great. Right. Thank you very much for spending time with us, and it's been a wonderful opportunity for me to get to know you, but also it's great for all of those participating in the Quality Awards to get to know you.
Yeah. Well, thank you. And may I offer my congratulations to all of you who are out there, who have either been entered for or have gained an award. Congratulations for doing an excellent job for which you are quite rightly recognised, and particularly to those I think have had some publications this year. Keep on publishing. That's the only way you can make sure that people get the message, is by doing it and writing it up and talking about it. Congratulations, and thank you for your kind questioning and for your hospitality.
Oh, thank you, Sir Mansel.
Thank you.